एक मिनट good morning, good evening, everyone. Nilesh, are you there?
Yes, madam.
So, Dr. Kastla is having some problem with sharing the screen. Can you just guide once?
Okay, I will do.
Sir, Kastla sir, can you just press the button of share screen? Does he need to be the host for that, Nilesh? Nilesh?
हाँ मैडम, मैंने कॉल किया सर को अभी.
Is my screen visible, sir? Kastla sir?
Yes, yes.
It is visible, right? And it is now moving also?
Yes, madam.
Kastla sir, can you see the screen?
Yes, it is visible and it is moving.
Okay, and can you see your chat box?
Yes, I can see the chat box too.
Okay, perfect. Then I will share the screen, and if I don't shift, then you can just ask me to shift the slides one by one.
Sure.
For the time being, I will stop the screen sharing.
Good evening, Rajesh sir. Hi, Sikha.
Good evening, good evening,
Hello.
good evening, good evening, Amrit.
Good evening, everyone, for joining in. We'll start in another 4 minutes.
Sikha, till we are waiting, you can update everybody about our upcoming activities.
Yes, ma'am.
Yeah, I was saying you can update about our upcoming activities for this month, May.
Yes. Yeah, so good. Hello, everyone. So, till we wait for 2 minutes, I would like to again invite you all for the 28th evening, that a musical, a non-academic musical evening that we have at Hotel Peninsula Grand. I hope all of you have registered for the same, and if not, please do register for the same. And you are all welcome with your spouses. So, it's a non-academic musical evening where we'll have a social get-together with everyone. It is from 5:30 p.m. onwards. On the same day in the morning, we have a small activity for the hemophilia patients as well. So we have circulated the same message in all the zonal groups as well. If somebody is interested, please do register for that as well. It's in the morning.
Also, in May, we are having 2 presidential action plan modules. 5th of May is IAP, which is at Leelavati. This is regarding respiratory and pneumococcal infections and management. And 19th of May is Gateway to Airway at Hotel Orchid. So these are 2 which are in May, and the details are going to follow again on our zones. So anyone who is interested has to register with the office. Registration is free but compulsory.
Okay, Kasta sir, can we start now?
Yeah, I think we can start. Sir is already joined.
Hello, sir. Hello, Vijay sir. I hope
Good
you can
evening,
hear.
madam. Good evening.
Okay, again, a warm welcome to all of you on the episode 3 of Webflix series by IAP Mumbai. And I'm happy to see people joining in such good numbers already. So today's session is on pediatric dermatology, and we delve into the fascinating world of dermatological health of our patients here. Our esteemed guest today is Dr. C. Vijaya Bhaskar. Sir is a renowned pediatric dermatologist. He's a professor, Government Stanley Medical College, Chennai, and has extensive work in this field. So he will be sharing his valuable insights, tips, and answering your questions regarding pediatric dermatology. To moderate the session, we have none other than our own Dr. Rajesh Kasla, sir, a renowned pediatrician from Kandivali, Mumbai. So without much ado, we'll start the session now, sir, and over to you, Kasla, sir. You let me know when you want me to share the screen.
Yeah, I think you should start sharing the screen.
Okay.
The first slide itself is Sir's introduction. So thank you, Dr. Vijay Bhaskar, sir, for accepting our invite for this particular Webflix session. And so, friends, as you all know, that almost 30% of our pediatric OPDs, we do come across a lot of 30% of the patients are dermatology patients, either with some primary lesion or a secondary lesion. And we common pediatricians are stuck up with the challenges of diagnosis as well as management of the cases. So today we have amongst us Dr. Vijay Bhaskar, who is a very learned, astute clinician whose genotype is pediatrics, but the phenotype is a pediatric dermatologist. Because sir was a pediatrician first, he has done DCH and then went ahead to do dermatology. So sir is doing exclusive pediatric dermatology work from Chennai, and I have heard him multiple times. And so we are really fortunate to have him here in our Webflix session. I've got 2 requests to all the attendees and delegates that please mute yourself and put your queries in the chat box. We'll try to answer most of the queries as much as possible in the stipulated time. And please refrain from taking the clinical pictures or the clinical photos which are going to be shown in the PowerPoints. So with that, without any further delay, I start the session and I go for the first slide. Yes, Sika, can you forward? Yeah. So with this picture, please see the picture and answer in the chat box what is the diagnosis. Next. So there are 4 or 5 pictures. Please go next slide, please. Yes. Next. So people have already started answering as scabies. Yes. And one more slide. Fine. One more. Next slide, please. Yeah, stop here. So with this last 4-5 slides, the diagnosis somebody mentioned was scabies. Sir, I would like to know from you what are the different type of scabies that we see in neonatal as well as the pediatric age group. What are the different types of scabies that we see and how do we manage them?
Very good evening to all, and I really thank the IAP Mumbai for giving me this opportunity. And the scabies is one of the commonest condition we come across in our practice. And treating scabies is not treating only the individual; the whole family has to be treated. That's one. Second, we have got different types of scabies. The first one is the classical scabies, what you would have seen in the first picture, where there will be hardly half a dozen to 1 dozen of itch mites in the body, not more than that. And the lesions you can typically see in the web spaces, particularly in the loose folds, in the inner aspect of the wrist, in the axilla, in the umbilicus, the nipple area, and also in the thigh region. These are the common areas where you can get the lesions. This is the classical scabies what we come across. But particularly the fourth picture and fifth picture you would have seen, any bizarre lesions in an infant, you have to think of scabies. And look at the palms and soles. Whenever see a bizarre lesions like this, you will see some vesicles or pustules on the palms and soles. And any bizarre lesion, the previous picture, before this, there is one picture. If you see any lesions like this, always go into the family history. Here you can also carefully note in the wrist of the mother, there is some few papules are there. So this is the typical scabies. The last picture, what we see in this series is it is the crusted scabies, where it's very difficult to make a diagnosis in the first thing. We may think it is psoriasis, or we may think it is eczema. It can be thought of in any way, but here it will present in a different way. This is crusted scabies. There is one more scabies called as animal scabies, where there will be a history of contact with animals, either the cats or the dogs, where the lesions will be present in the inner aspect of forearms, lower part of the abdomen, and thighs. These are the areas we commonly come across. And there is one more condition called as scabies in clean, because people are very clean. They may have itching, but they may not have any secondary impetiginous lesions at all. And there is one more scabies called as scabies incognito, where you will have the typical lesions, but you will not have itching. Probably the patient will be immunosuppressed, or the patient may be a diabetic, or the patient may be having some malignancies, or some immunosuppressions will be there. So these are the different types of scabies. Of course, the treatment is going to be the same. So any child, presently the treatment of choice is going to be permethrin, 5% permethrin king, which can be used above 2 months of age group. Above 2 months, it can be safely used. You have to apply from the retroauricular area, below the neck, throughout the body. And if it's an infant, you have to leave it for 8 hours. If it's a child, we can leave it for 10 hours. If it's an adult, you have to leave it for 12 hours. And after that, you can give a bath. And the dress, what they have worn in the previous day, those dresses, the bedspreads, bed sheets has to be washed, so rinsed in hot water, and you have to dry it in hot sunlight. This is how we treat. And more important thing is, the main reason why children are brought to us is mainly for the itching, right? So you have to give antihistamines for a minimum period of 3 to 4 weeks, because the itching is due to the hypersensitivity reaction, and 1 week or even 5 days of antihistamine will never help us. So you have to put them on 1 month of antihistamine and tell them the disease will get cured in 1 day, but you have to use it. The itching will be persisting, so you have to use the antihistamines for 1 month. And I always use double antihistamines, as non-sedative in the morning or a low sedative in the night. I always use double antihistamine so that the itching can be brought under control. If there are any secondary infections, they has to be like an impetigo, has to be treated accordingly. This is how we manage. And the other drug which we can use is topical ivermectin. Topical ivermectin also can be used, but that has to be used above 6 months of age group. The same way we can use topical ivermectin above 6 months. And below 2 months of age, sulfur is the recommended treatment. Normally, we have to use 3 to 5% sulfur. It is not readily available. You have to dispense it. By a chemist has to dispense it. Very difficult to get. It is very messy. It stains the cloth. It stinks. And it is very difficult to use it. So even below 2 months, I still use permethrin only, because the FDA has not told that it is contraindicated. There are many studies below 2 months of age group. And the next thing is the use of oral ivermectin. You can use oral ivermectin above 5 years of age group or above 15 kgs. Either one of these criteria has to be met. you can give 0.2 milligram per kg body weight, the maximum dose of 12 milligram stat, and you can repeat it after 1 week. The recent drug that has been approved in US, which has not come to India, is spinosad, 0.9% spinosad. I think we'll get it very soon in India, but that is recommended above 4 years of age group.
Okay. So that the older drugs which we used to have, the gamma scab lotions and scabex lotion, all these things are given up. We only use permethrin.
Yes,
And
sir.
do we need to repeat permethrin after a week or 10 days, or it's a single application?
Definitely, we have to repeat it after 1 week, thinking that there may be some mites that may be still are the eggs which could have become a mite. So it's better to use it, repeat it after 1 week, sir. And gamma benzene hexachloride, still we use it in our government setup. We still use it, but it is recommended about 2 years of age group, not below 2 years. When better drugs like permethrin is available, why do you want to go for the older drugs?
Yeah, and if at all gamma benzene hexachloride is used, then the frequency has to be daily, right?
No, sir. It is also once application. Again, repeat it after 1 week only. It is only 25% benzyl benzoate lotion, which was available earlier, where you have to use it for 3 consecutive days.
Okay.
Benzyl
And
benzoate lotion.
whenever we see an index case of scabies like this in pediatric age group, we have to treat the family as well, irrespective whether they have the lesions or not.
Yes, they may be in the incubation stage, so they may not have itching at that particular point of time. So people who don't have itch don't need to give antihistamines, but everybody has to be treated with permethrin on the same day. It has to be done. Particularly if it's a lactating woman who is going to give feeds to the baby, she also has to apply. But in the night, in case she wants to feed, she has to wash the breast, feed, again reapply the medicine after feeding the baby. Like that, any number of times you can do within that 12 hours.
Okay, sir. I think we have answered all the questions related to scabies. I request all the delegates to please put the questions on the chat box related to that particular topic, because we'll be shifting to different conditions now. So, Sikha, can you have the next slide? Yeah. So, diagnosis.
Itchy condition, it comes and goes.
Yeah. Yeah. So already people have started answering urticaria. This we see left, right, center. So there's no doubt about it. This is urticaria. So the question is that how long do we give antihistaminics, and are there any role of newer antihistaminics that are available now, the non-sedating one? And what about the local application? What all things can be used?
Yes. So urticaria, I always say 3 simple E's. The definition is 3 E's: erythematous, edematous, evanescent rash. It comes and it disappears. If it is below 6 weeks duration, we call it as acute urticaria. If it is more than 6 weeks, we call it as chronic urticaria. It is not like diarrhea, acute diarrhea or chronic diarrhea. Here it is 6 weeks is the cutoff time. And what I would like to tell the pediatrician is, you treat all acute urticarias, don't send it to the dermatologist. But most of the chronic urticarias are even difficult for the dermatologist to handle. So if it is going to be chronic urticaria, it is better to refer to the dermatologist. So first of all, you have to remember what could have triggered this urticaria. That is very important, because if you're able to find the cause, then it is easy to treat. Remember all eyes. One, it could be an occult infection. It can be some ingestion of drug or ingestion of any food that can cause it. That will be a close relationship. The drug you have to take all 3 weeks before, whatever the drugs they have taken, that has to be taken into account. And the next is inhalation. Your dust mites, pollens, all those also can cause. And another eye is ingestion, your insect bites, and infestation also be taken into account. And the biggest part of eye is idiopathic. Sometimes it's very difficult to find out a cause. So you have to, it's very difficult to find a cause for this. And the patient comes to you on the first day with acute urticaria, and if you have ruled out infection, you can boldly start them on steroid, short course of steroids for 3 to 5 days. You can give prednisolone, 0.5 to 1 milligram per kg body weight, and you can abruptly stop the steroids. And I always use double antihistamines for steroids, or you start with just antihistamines. You at least give it for 3 to 4 weeks in acute urticaria, because sometimes it is very difficult to find out the cause. And the safe antihistamines that can be used is below 6 months. You all know that we can use chlorpheniramine maleate, and we can use your hydroxyzine hydrochloride. Above 6 months, we use fexofenadine or levocetirizine, or cetirizine can be used. And above 2 years, we use loratadine. And bilastine also can be used above 2 years. People will 6 years it can be used, but now there are a lot of studies which have shown that it can be used above 2 years of age group also. But strictly as per the FDA, we use it above 6 months of age, 6 years of age.
Yes,
And
sir,
in chronic urticaria, we give antihistamines for years. Sometimes we give it for even 1 year, 2 years. Nothing is going to happen. So definitely we can deal. And out of 100 people of urticaria, at least 20% will turn out to be a chronic urticaria. 80% will definitely, they become all right. But 20% will definitely start as an acute urticaria and they will end up with chronic urticaria. And chronic urticaria, it's sometimes very difficult for us also to treat. So whenever you see a chronic urticaria, you better refer to the dermatologist, particularly the dermatologist which you don't like. That's the best one because it's very difficult for us also to manage. That is one. Second is, there are some food restrictions. Normally we say, we have to take it with a pinch of salt. Normally we say seafoods has to be avoided during the acute episodes. And also you have to avoid, sometimes we say brinjal and any artificially colored items, which can trigger the urticaria, like chocolates, ice cream, cool drinks, such type of things can be avoided during the acute episodes of this urticarias.
Sir, two questions here. Is there any, is there a role of Ebastin in
Definitely, sir.
urticaria?
We can use Ebastin.
Okay.
I get control with fexofenadine, levocetirizine, or cetirizine itself. I do use Ebastin, but I don't use that frequently, sir. You can use it.
And for chronic urticaria, do we recommend any skin tests, patch test needs to be done to find out to what the
Normally, for a wheezing, it may be helpful, sir. But generally, this prick test has got more of false positive and false negative also. So I don't recommend any test. But in chronic urticaria, one more thing I would like to reiterate is, in acute urticaria, do not investigate. Because nothing you can find out in acute urticaria. Maybe you can see mild elevation of eosinophils or IgE may be elevated. We are not going to do anything for that. So in acute urticaria, do not investigate. But in chronic urticaria, you have to rule out other autoimmune diseases like thyroid and B12 deficiency, like hemoglobin can be done, and thyroid profile can be done in these patients. And you can rule out any dental or ENT sepsis also, you can rule out in these type of patients. And routinely in acute urticaria also, we deworm, but not during the acute episode. Maybe after a week, we generally deworm. Sometimes when you deworm at this time of urticaria, it can aggravate also.
Is there any connection between ANA positivity and chronic spontaneous urticaria?
In chronic urticaria, when they are not responding to the routine management, we have to do an ANA also. But immediately we don't do after 6 weeks, but we'll wait if they're not responding, particularly in a female child. Yes, we do ANA because sometimes the collagen vascular diseases can start as an urticaria itself.
Sir, 3 more drugs people have asked. Is there any role of ranitidine in urticaria, montelukast, and when do we use methylprednisolone? In extreme cases, is it used?
Yes, sir. So that's what, as I said, even in the acute phase, you can use methylprednisolone or prednisolone, but for a short course, one. Second, in case of chronic urticaria, we don't recommend any steroids at all. The moment you start them steroids, they'll become better. The moment you withdraw, they'll have the problem. So then it will be very difficult to stop steroids if we're going to use it in the chronic urticaria. And the other question you asked was
montelukast.
Montelukast. Yes, montelukast for chronic urticaria. For acute urticaria, I don't use. For chronic urticaria, yes, it has a role. The mast cell stabilizer can be used for chronic urticaria along with antihistamines. One. And the role of ranitidine, actually, what is the main role of ranitidine is to bring down the it has got receptors in the vessels. So it will bring down the vasodilatation. So the edema and the erythema goes down. That way it will help. That is also used only for chronic urticaria. For acute urticaria, we do not use ranitidine. We use it only for chronic urticaria along with H1 blockers. Because ranitidine has no role in control of itching, but it will bring down the edema and the erythema.
Okay. Role of local pramoxine. Some anti-itch lotions.
Yes, it is an anti-itch lotion, sir. I have used so much of this for topically also. I didn't have much benefit, sir. This, to be very frank.
Okay. I think we shift to the next topic. Next slide, please. We go to hypopigmented lesions in pediatrics. So, any guess for this slide? There is this hypopigmented lesion on the face. Yeah, so the answer has come as P. alba. Somebody said it is post-inflammatory. Somebody said it is a scar, and somebody said it is Pityriasis versus. So here it is. We pediatricians, common pediatricians get confused. Sir, your expert opinion.
Sir, actually,
Or
it's
this-
one of my close to my heart topic. So
Okay.
because then it is one of the breadwinners for us also, because lot of hypopigmented patches comes,
Yes.
and whenever there is an hypopigmented patches, people rush to us, particularly pediatric age group. They rush to us because in India the most dreaded disease what they don't want to have is vitiligo, right? So many
Yeah.
people say the moment you say this is not vitiligo, they're more happy. They don't even bother for the other diagnosis or the treatment. So that you have to differentiate. So whenever a hypopigmented patch comes to you, there are two ways of doing it. One, you see whether there is any scaling or not. Here there is scaling actually. So there is scaling or no scaling. If there is scaling, we have 4 common diagnoses. I'm talking about only common diagnosis. 4 conditions we can think of. One is Pityriasis alba, another is Pityriasis versicolor, another is polymorphous light eruption, and sometimes you can have it in seborrheic dermatitis also. These are the 4 conditions you have to think of when there is scaling. And when you see,
Sika, can you just go through the next 2 or 3 slides? Those photographs are. Yeah.
you can see the scaling very well in this particular picture. And here also I can see that scaling that is there, right? So this is another hypopigmented patch, again with scaling. So these are the common things we can come across in our practice, right? If we go back to the first slide in this hypopigmented series, actually there are 3 stages for Pityriasis alba, but this is the first stage. What you see in the screen is the first stage where you have an erythema and the hypopigmentation. And then the scaling will be elevated also. Normally we don't come across this stage. We normally come across the second stage, what you have seen in the second picture. You can have a scaly hypopigmented lesion. So how to differentiate between these conditions? So you should look at the borders. You look at the borders, they have an irregular border or ill-defined border. You can come to the next picture. So you can see that the borders are irregular border you can see, and good amount of scales. It can be a single patch, it can be a multiple patch, and they are asymptomatic. You will not have any itching, nothing. It can not only occur on the face, it can occur on the trunk also. So ill-defined border, asymptomatic, scaly patches, Pityriasis alba. The treatment here is just reassurance is more than sufficient, but if you reassure, the patient will go to the next doctor. Because they have a patch and you say it will become all right on its own, definitely it will become all right on its own, but they don't want to wait. So either you can go for an emollient or you can go for hydrocortisone. Simple hydrocortisone cream for a period of 2 to 4 weeks is more than sufficient for this condition to disappear. But recurrences can occur. Initially, when I was a postgraduate, everybody used to tell it is due to worm infestation and it is due to multivitamin deficiency. In those days, we used to do deworming and give multivitamins for 3 months, it will disappear on its own. But we all know that now it is an endogenous eczema. It is one of the commonest condition in atopic dermatitis. It is the commonest manifestation of atopic dermatitis, but not all P. alba are atopics. But it is very common in atopic dermatitis. That is how you treat the Pityriasis alba. Now, what you see here, this child has got again a hypopigmented patch. You can see multiple patches that is present. This is again Pityriasis alba. The same type of treatment will be okay. And you have to tell the parents that it may recur up to 15 years of age. It can recur, it can come and go because it's an endogenous eczema. So reassurance, topical emollients and steroids is more than sufficient for this. Okay. And coming to the next condition with scaling. So can I have the next picture? Look at this. Look at this. You can have again a scaly lesion and again a hypopigmented lesion, but look at the borders. Can you look at the borders? They are well-defined borders or pencil line borders, you can tell. So well-defined borders. When you have well-defined borders in the seborrheic areas like face and trunk, then it is Pityriasis versicolor. Versicolor means various colors. Pityriasis means brawny scales, brawn-like scales. That is how the name has come. So this is caused by malassezia. Again, this malassezia is present in every one of us, but we all don't develop this Pityriasis versicolor. People who are genetically prone only, they develop this Pityriasis versicolor. So even if you treat them, there will be recurrences again. Here we give simple topical clotrimazole is more than sufficient, twice daily for a period of 6 weeks. It will take care of the conditions.
Okay, next slide.
And you can see here the versicolor, I told you, the various colors, right? In the face, you can see hypopigmented, or in the trunk, you can see a pigmented lesion. So this is the reason it is called as chromic and achromic Pityriasis versicolor. So here there will be extensive lesions, particularly in the adolescent age group. On the face, again, you can go for only clotrimazole cream twice daily for 6 weeks. But on the trunk, when there are extensive lesions, the best drug of choice will be 2.5% selenium sulfide or ketoconazole lotion can be used. You have to apply below the neck, up to the arms, up to the waist, even if there are no lesions, because the spores will be there. Better apply below the neck, up to the arms, up to the waist. Leave it for 10 minutes and then give a wash for 2 weeks once daily. Once daily for 2 weeks is more than sufficient. You can get a mycological cure. The fungus will disappear. But the color to change, it will take another 4 weeks. The cosmetic cure will occur only after 6 weeks. So the medicines need to be applied only for 2 weeks. And here, oral fluconazole can be given. We all know that oral fluconazole, the dosage is 3 to 5 milligram per kg body weight. But in this condition, we give 8 to 12 milligram per kg body weight stat dose and repeat it after 1 week. And the maximum dose that can be given at a time is 400 milligram stat we can give it. Not more than that, depending on the age group.
Yeah. Can we have the next slide?
Actually, if you see, this child has got a bilateral, that is almost symmetrical lesions that are present, and hypopigmented lesions. If you look carefully, there will be mild central hyperpigmentation surrounded by hypopigmentation. And this child had itching. The child had itching. Whenever they go out in sunlight, they have itching. This is the typical symptoms, right? So the other two conditions, what we saw, they do not have any itching. But here, the child will complain of itching or burning sensation whenever they venture into the sunlight, and it will be present in the sun exposed areas. So this is, yes. Anybody?
For somebody who answered photosensitive dermatitis.
Yes, it is otherwise called as polymorphous light eruption.
Light eruption.
PMLE. Yeah. Polymorphous. It can occur in different morphologies, so it's called as polymorphous light eruption. So here the treatment is again going to be topical steroids. I think I will come to the what type of steroids to be used in different location. Here again you can use hydrocortisone or desonide can be used here. So topically you can go for steroids to take care of the lesion, and you have to give sunscreens. Sunscreen is very, very important. So you have to apply a sunscreen, particularly the physical sunscreens. We use it in children. Your zinc, micronized zinc is there that can be used on the face. You can use it not only on the face, on the sun exposed areas. You can use it in the morning at 8 o'clock, again at 12 o'clock, they have to apply. And that will take care of the lesions. The further lesions will not occur because of that. And here they will have itching. So you have to give antihistamines also along with this.
So what are the preferred sunscreens that are available? And there is something called as SPF
yes,
factor.
Sir. There is sun protection factor. We call it a sun protection factor. It's nothing but it is a formula that is given. But let me put it in very brief thing. Like any sun protection factor of 15 or 15 to 30 is more than sufficient for any individual. And most of the sunscreen we use in pediatric age is going to be micronized zinc. Micronized zinc, which is nothing but a physical sunscreen where it will repel the ultraviolet radiations. And whereas the other sunscreen, what we use in adolescents and all, will contain, they contain the chemical sunscreens that are used actually, like our benzene and other things. But in children, we give micronized zinc that can be used. It can be safely used above 6 months of age group. Any sunscreens, you can use it above 6 months of age group itself, you can use it unless they have an issue. When there are no issues, you don't need to use a sunscreen as a routine. But when they have an issue like this photosensitivity, you can go ahead with sunscreens.
May I request Dr. Renuka, please mute yourself. There's a lot of disturbance. Nilesh, can you mute the delegates, please? Nilesh?
Sir, done.
Okay. Fine. So we go to the next
sir, before we go this, sir, one more picture, I think I may not have that. Seborrheic dermatitis. I told you they have a asymptomatic lesions. It will be small hypopigmented lesions. It will be there. And they may have dandruff along with that. There will be definite dandruff that may be present in that. Again, hydrocortisone can be used for the face lesions. And you can go for any ketoconazole preparations for dandruff.
Can you suggest any brand names for sunscreen? Because it's a very commonly asked prescription from us.
As I told you, a zinc preparation is always preferred in case of children, sir. So what you can do is, there is a sunscreen called as Suncross. I don't know whether I can mention the trade names in the forum. It is Suncross Soft Gel, which contains micronized zinc, or you have L-Free, ELFRI, yes. And you have again that Sunstop 19 is also available. These are few sunscreens which you can safely use in children.
Okay, fine. So we go to the next slide. Yeah.
So we were talking about the hypopigmented patch with scaling. So I told you these 4 conditions, but whenever there is no scaling, then always the first and second and third diagnosis from my side, particularly in coastal Tamil Nadu, Andhra Pradesh, Orissa, we normally think of Hansen's disease. The first and the foremost diagnosis we think of. The second diagnosis will be early vitiligo, whenever there is an hypopigmented patch. And third, it could be a nevus anemicus or nevus acromicus, which may be present from birth. And it can be post-inflammatory hypopigmentation. That is, you get an impetigo or you get some skin lesion. When it heals, it can heal with hypopigmentation. They all will be non-scaly. Or there may be use of some cosmetics or use of some steroids that can lead to hypopigmentation. So these are the 5 or 6 common conditions we have without scaling. And some cases you can't treat as a pediatrician, you have to refer to the dermatologist. Some you need not treat because it will disappear on its own. And some it will persist, whether it's a pediatrician or a dermatologist, we can't do anything. So maybe we will see one by one. This is this non-scaly lesion on the face, a hypopigmented lesion. Always think of Hansen's disease or leprosy. Particularly tuberculoid and borderline tuberculoid are common in children that we come across. Particularly when you have a lesion on the face, it is very difficult to test the sensation also, because face is bilaterally distributed. You have bilateral innervation and multiple innervations are there, so you may not be able to see for the sensation. You have a doubt, you can ask the child to exercise or go stand in sunlight. The child may sweat in other areas. When the autonomic nerves are gone, she may not sweat on the patch. That is one indirect way of making a diagnosis. Or still we have a doubt, then you have to do a biopsy to make a diagnosis of Hansen's. And all Hansen's disease in children are easily treatable. The hypopigmentation also may disappear after the treatment. We normally give possibacillate treatment. Like these type of lesions, we give only dapsone, and monthly once rifampicin dosage, we give it for 6 months, they become all right. So this is very easy to treat, but in case you make a diagnosis of Hansen, it's better to leave it to the dermatologist. Can I have the next picture?
Yeah, next slide.
So this of course you have seen that the diagnosis is there. This is an ashy leaf macule where you can see the hypopigmented patch, which may be present at the time of birth itself. You can see a broad end on one side and a tapering end on one side. This may be present from birth itself. So again, you have to just make a note in the case sheet at the time of, make a record in the notebook, so that later if the child starts throwing convulsions, we know that there is going to be some CNS involvement. It's going for tuberous sclerosis complex. But for the patch, we are not going to do much for the patches here.
Next slide.
I think some slides are missing.
There's one slide. Dr. Sika, one previous slide, please. Yeah, this one.
So
the picture is missing.
No, this picture is missing. There is
Yeah.
hypomelanosis of Ito. There is a condition called as hypomelanosis of Ito, which can occur in one side of the body. It can occur in the half of the body itself. And there may be associated CNS, skeletal and ocular abnormalities may be present. It is not always it is present, but we are not going to do anything for the hypopigmentation. And another is nevus anemicus and nevus acromicus, where you have the hypopigmented patches from the birth, and as the child grows, it will slowly increase. In the size proportionately will increase. Again, here we are not going to do much for that. But the most problematic thing is an hypopigmented patch, which is non-scaly to start with, but can end up with the depigmentation, is nothing but your vitiligo. Vitiligo is one condition which can start as hypopigmentation. Sometimes it's very difficult to make a diagnosis of early vitiligo, but once it becomes depigmented, we all know that it is vitiligo. And vitiligo can be treated nowadays. There are a lot of therapies that are available, including the steroids that can be given, topical tacrolimus that can be given, ultraviolet radiation can be given, and so many methods of treatments are available. So please give hope to those patients when they have come with vitiligo that it will disappear. Sometimes it may take even a long period of time to disappear, but definitely there is a lot of treatments available for vitiligo. So kindly you encourage the patients to get the treatment for vitiligo and they will become all right. And sometimes you will have an hypopigmented lesion with after some impetiginous lesions or after some injury and all. Those are post-inflammatory hypopigmentation. There will be history of some skin lesions prior to the onset of hypopigmentation. Just leave them alone or give a moisturizer. It will disappear in the due course of time. And sometimes nowadays, particularly adolescents, they use a lot of cosmetics. So they use cosmetics and they use a lot of steroids also for brightening the face. So that also can cause hyperpigmentation. A thorough history will bring us out this application of steroids. You ask them to stop steroids and you start applying some emollients and they will become all right. So the hyperpigmented patches can be divided into like scaling and non-scaling. All the scaly lesions you can treat, no issues at all. And non-scaly lesions like Hansen's, you can refer to the dermatologist. Vitiligo also, you can refer to the dermatologist. And nevus anemicus, tuberous sclerosis, those type of patches, we are not going to do anything. Post-inflammatory pigmentation is going to disappear on its own, and post-steroid application hyperpigmentation also will disappear on its own. Just give an emollient and just wait for some time, it will go.
So the carry-home message here is that scaly lesions is pediatrician's domain, non-scaly lesion is referred to the dermatologist.
No, only 2 refer to the dermatologist. Yeah. The rest 2, nothing can be done. And the next 2, it will disappear on its own.
Okay, sir. So is there a role of levamisole in vitiligo treatment?
Yes, sir. It is given as an immunomodulatory therapy. We give as an immunomodulatory therapy. We rarely do, but it is not the sole treatment. It is only an adjuvant treatment for the other treatments. We do use levamisole twice a week, 1 to 3 milligram per kg body weight for 3 to 6 months we use.
Yeah. Dr. Sikha, we move to the next slide now, which is all a set of all skin bacterial infections that we see in day-to-day practice, especially in summers. So, yeah, people have already started putting the diagnosis as impetigo. Yes. So, sir, we will show the subsequent slides, but we are really confused. What is the difference between pyoderma, impetigo, erysipelas, folliculitis, and furunculosis? Are there, is there a difference in the treatment, yes, or the treatment remains the same?
Definitely there is a difference. Impetigo is nothing but the superficial skin infection, bacterial infection, we call it as impetigo. Pyoderma is any bacterial infection of the skin, we call it as pyoderma. And when the hair follicle is involved, we call it as furunculosis. When it's superficial, when deeper hair follicle is involved, we call it as folliculitis. So hair follicular involvement, then we call it as furunculosis or folliculitis. Whereas superficial skin lesion, when it occurs, we call it as impetigo. Impetigo, the literal meaning is to boil out, right? So it just like that boils out, or it's like fire. It spreads like a fire. The first day you may see a single lesion, yes, and the second, third day you can see multiple lesions occurring on the face. So this is impetigo. Erysipelas is nothing but, again, it's a bacterial infection with a lot of erythema that will be present in the thing. There may not be any other structural changes that may be present. So everything is different. So this here is an impetigo.
Can you show further slides? I think sir is talking about those. Yeah.
This again is an impetigo only.
Yes.
Next child is going for SSSS, right? Staphylococcal scalded skin syndrome.
Yes. Next slide.
This again, SSS is in a 9-day-old baby. This is a 9-day-old baby. We had it 6 months back in our hospital.
One more slide. Next slide.
This is a child after treatment for impetigo who was going for SSSS, started improving within 3rd day.
Next slide.
This is furunculosis. This is furunculosis, which is very painful. You can see that the cry on the face, right? So it is very, very common during summer seasons. And people, most of the time, they blame it on mangoes, because mangoes also come only during the season. So it's nothing to do with the mangoes. So this is a bacterial infection, particularly in the summers, it is very, very common. You can see the hair follicular involvement here. And you can see it will be a painful conditions. Unless it breaks open, the pain may not subside. The treatment is going to be same for all. So this is furunculosis, what you see. And what you see in the scalp, particularly in patients who have dandruff, the small lesions on the scalp, they are called as folliculitis. Infection of the hair follicles, particularly the deeper hair follicles, we call it as folliculitis that will be present, right? So these are the few differences. So let us go to the first slide. So how do you manage this impetigo? So impetigo, either you have bullous impetigo or a non-bullous impetigo, and they say sometimes may have an honey color crusting that may be present. So when you have an impetigo, when the lesions are very few, 4 or 5 lesions are there, only topical treatment is more than sufficient. The best treatment still today, the drug of choice is going to be mupirocin. Topical mupirocin, thrice daily for a week will be enough. And if there is a lot of pus in an area, then we can use fusidic acid, because fusidic acid can penetrate a pus-filled area. So you can use fusidic acid in a pus-filled environment. And the latest drug what we use nowadays is ozenoxacin. Ozenoxacin is a drug which we use for 5 days is more than sufficient. Twice daily application is more than sufficient for impetiginous lesions. When there are more than 5 lesions, then it is better to go for oral systemic therapy. And the best, still I will tell you, the penicillin group of drugs are the best for this because they are caused by Staphylococcus and Streptococcus. And my drug of choice is cloxacillin, but nowadays we don't get isolated cloxacillin. So the next drug of choice is going to be cephalexin. Cephalexin is a wonderful drug. Of course, you can use amoxicillin or even your, amoxicillin, clavulanic acid preparation can be used, but the best drug of choice will be cephalexin. If you are able to get cloxacillin, that will be another best drug of choice that can be there. So, but whenever you see an impetigo in a child, particularly below 6 years of age group, just spend 1 or 2 minutes time to undress the child and look at the axilla and groin also, because this child may go below 6 years of age, they may go for the complications like staphylococcal scalded skin syndrome. The first peeling may start in those areas, in the axillary or groin areas or in the flexural areas. If it is so, the earlier you treat them, they need not need admission also. So you can easily manage with topicals and oral antibiotics itself. So always spend some time, because below 6 years of age group, this Staphylococcus releases an exfoliating A and B toxins, which are normally excreted through the kidneys. But children's kidneys below 6 years are not mature enough to excrete these toxins. So they are more commonly, they develop staphylococcal scalded skin syndrome. If it is clear-cut SSSS, then it is better to admit the child and give IV cloxacillin, or you can go for IV clindamycin can be given. You can go to the next slide where I can show you an impetigo. You can see the impetigo on the right side of the face, but you can see small bullous or vesicles that are started developing the neck regions. And within hours, this child started peeling all the skin in the flexural areas completely. So this is how it progresses very fast. So here you have to admit, and you can put them on IV antibiotics in the form of either clox or clindamycin. They become all right. The first 3-4 days of IV antibiotics more than sufficient. Then you can switch over to oral cephalexin. You can come to the next slide.
Here we have, okay.
So this is another child who had impetigo in the eye region, but see that the child has started peeling. Within a day, this child started peeling of skin on the face and also in the neck regions. So this is how it starts. It starts in a small area, but it can progress very fast. That is one.
We have two questions in the chat box. How to differentiate this SSS, scarlet skin syndrome, from Stevens-Johnson syndrome? And is there a role of skin biopsy in SSS?
Yes, you can do a skin biopsy for theoretical purpose, but it's a clinical diagnosis. Normally, it's a clinical diagnosis. In SJS, you can see there will be some history of drug, or sometimes some other infections like a mycoplasma may be there, or herpes may be there. But there, the typical skin will peel, the mucous membrane will get involved in SJS. But in staphylococcal scalded skin syndrome, no mucous membrane will get involved. In SJS, the definition itself says you have to have 10% of body surface area of skin involvement with minimum 2 mucous membrane that has to be involved. So in SSSS, there will not be any mucous membrane involvement. That is an easy way to differentiate from SJS.
Okay, sir. So we move to the next slide.
So this is a 9-day-old child, sir. We had the impetigo. I mean, we had a bullet impetigo on 3rd day of life, and within 9 days, the child started developing SSSS, and we successfully treated with IV antibiotics. This is after 3 days of treatment. You can see the marked improvement in the child.
So these are usually methicillin sensitive staph, right?
Yes, sir. Even if it's resistant, clindamycin works for it, sir. Even if it's MRSA, clindamycin will be the drug of choice. So here again, the topical antibacterial, this furunculosis, topical antibacterial may not be of much useful here because it's a closed lesion. So again, the same cephalexin or your amoxicillin with clavulanic acid can be the good drug of choice here. They'll become all right. But I would like to bring to the notice that there are some children whom you give cephalexin this time, they may become all right. And after 2-3 weeks, again they come back with furunculosis. Again, you try amoxicillin, clavulanic acid, they become all right. Again, they can come back to you. That's called as recurrent furunculosis, right? So whenever you come across such a type of children with recurrent furunculosis, please think of 2 or 3 conditions. One, they may be carrying infection elsewhere in the body. So they are called as carriers. One. Second is there may be iron and zinc deficiency may be a possibility in these children. Third, immunodeficiency may be a possibility. These three things you have to have in mind when they come with recurrent furunclosis. And in my practice, most of the time we have seen that there will be carrier state. So these carriers will be present in the nares, in the nose, in the umbilicus, in the perianal region. So what you have to advise is, you have to give mupirocin. You can apply in the anterior nares, in the umbilical region and perianal region twice daily for a period of 10 days. And along with that, we give rifampicin also, rifampicin 10 mg per kg body weight for 10 days to take care of the carrier state. And most of the time we are successful that there will not be any recurrences.
Okay. So we go to the next topic now. These are warts.
Yes. So warts, we all know it's caused by a virus and it's caused by human papilloma virus. And we have almost another, at least 200 family members in this. HPV 1, 2, 3, 4 like that. Almost 200 members are there, but only a few members will affect the skin. And they are all superficial. They are present in the epidermis. They are not directly in contact with the blood vessels. That is the reason it takes a long time for this to disappear, right? So most of the time, this will disappear on its own. It may disappear on its own. It may take weeks or it may take months together. But when parents are more worried and you think that there is a lot of spread of this viral warts, we can go for treatment. Because there is no oral drug there is no antiviral drug which can be effective against this viral wart. So we have to go for destructive therapy. We normally use salicylic acid 16.7% solution with lactic acid in a collodion base. It's ready-madely available. And you can apply this medicine, even though it's an acid, there will not be any pain. You can apply the medicine, you can, on the surrounding area, you can apply Vaseline, so that by mistake, the medicine falls in the surrounding area will not get affected. And you can apply this acid medicine on the wart in the night. In the morning, you can wash it off. Within 30 seconds, it will dry up and it will not cause any pain. And after 2 to 3 weeks, the skin will start peeling. Still continue to apply the medicine. At one point of time, when you reach the normal skin, the child may complain of mild pain. At that time, you can stop the treatment. That is one. But if the same lesion is present on the face, we cannot use an acid. You cannot use an acid because sometimes it can leave a scar which can be permanent throughout their life. So don't use it on the face. And sometimes we give oral immunomodulatory therapy in the form of either levamisole can be used or zinc, 10 milligram per kg body weight. Zinc, oral zinc, we can give it as an immunomodulator therapy daily for 2 months. Or levamisole on weekends for 3 months, you can use it. To some extent, it will help. But still the lesions are present on the face, then it is better to refer to the dermatologist, where we normally do an electrocautery or we do a laser and remove it. Sometimes we do cryotherapy also to remove it.
Sir, is there a role of selectin paint here?
That selectin paint is only 16.7% salicylic acid and lactic acid base.
Okay.
The trade name is Selectins.
Does the HPV vaccine is effective against prevention of these warts?
No, sir. That is only for 16 and 18 to prevent cervical cancer, not for this, because these are all caused by 1, 6, 8 like that, sir. So it is not that particular type which is, so vaccine is not possible because there are 200 family members here.
And the dosage of zinc that is mentioned at 10 milligram per kilogram is quite a high dose. So
but still, that is the dose which is given, sir. Normally, each 3 milligram will come to 1 gram of elemental zinc, if I am right.
Yeah. Okay, sir. We proceed to the next slide, Dr. Sikha. Yeah. So so there are 2 or 3 such slides. Next, we'll show those 3 slides next, and one more. Here the diagnosis will flow, sir, because this we see in epidemics. So this is hand-foot mouth disease, no doubt about it.
So everybody knows this hand-foot and mouth disease, and we all know that it is caused by Coxsackie A16 and also enterovirus 71. But the only problem why I brought this slide is, normally so far we didn't have any issues at all with HFMD. Whether you treat or not, you reassure them. If you want to write some calamine lotion or antihistamine if there is itching, most of the time there will not be any itching and you collect your consultation fees. Normally it disappears on its own. Whenever they have oral lesions, we find it difficult because they are not able to swallow. Sometimes we rarely admit them and give IV fluids also, very rarely. But the only concern we have to have a look is, whenever it is caused by an enterovirus, it occurs in a very severe form. Sometimes it can lead to CNS and lung complications can occur due to this enterovirus. So that too you have to have in mind. So any child who's progressing very fast and you see there is some CNS or lung involvement, you better admit and you can start them on IVIG, or we have to go for an antiviral drug called as fleconazole. That is the reason I thought we'll bring this into account. But so far, we didn't have any issues with HFMD, but there have been so many epidemic deaths that has occurred in other countries. So we have to have an open mind and watch for this complication that may occur.
Yes. Yes. Next slide. Next. Yeah, sorry. So this is obviously molluscum, which is again a very common infection that we come across. So what are the different treatment modalities available over
Sir,
here?
actually, again, reassurance is more than sufficient. But again, as I told you, no mother or parents will keep quiet if you say reassurance. They will switch over to the next doctor. So whenever you see a molluscum, particularly we see a dome-shaped hemispherical lesion, sometimes you'll get a punctum also that may be present, a depression that may be present on this. So the best treatment will be needling. If the child cooperates, that's the best treatment I can tell is needling. You remove, you put a needle through and through, and you can just open it up, and you can take away the molluscum body that may be present here. Unfortunately, I have a video, but I'm not able to play here. So we can remove that in that way. Second is, if the child is not cooperating or the parents are not cooperating, you can still use 5 to 10% KOH, potassium hydroxide. We normally use it for staining the fungus, right? But it's not ready-madely available. You can prepare 10% KOH, sir. You can buy the potassium hydroxide crystals. That is very cheap. And you can have a weighing machine. You take 1 gram in 10 ml of distilled water, you mix, it will roughly give 10% KOH. You can apply twice daily for a week. What it does is, it produces an irritant dermatitis, and instead of putting the needle, this KOH will act as an irritant, and it will open up the lesion and it will throw the molluscum body out. That's a simple way of managing molluscum contagiosum. But most of the dermatologists, they would prefer for needling. Even you can do needling. It is very, very simple. You can put a needle, 24 gauge needle through and through, and just you lift it and you can open it and you can squeeze the molluscum body out. And most of the time we charge around 100 to 200 per lesion. So if you have 50 lesions, you can close your practice on that particular day after removing all these things, right? So that is one. And second thing I would like to concentrate here, if you see any children with molluscum, without molluscum elsewhere in the body, but it is present mainly in this area, always have a high suspicion of sexual abuse also in your mind. You have to think that in the mind, but it may not be always true, but always have that in your mind, particularly when the genital, near the genitals, they are present without any molluscum elsewhere in the body. Think that also in mind. That is very important.
Okay, sir. Is there any role of injecting a low-dose MMR vaccine into these lesions? I had heard about such a study. Is it?
Yes, sir. You can inject, sir, but it is not worth it, sir. Okay. Instead of injecting, you put a needle and remove it, sir. That will be the better option, I feel. Okay. Definitely, even for what we can use MMR, all those things we can use it, but normally it's not worth it.
Yeah. And are there any side effects of using KOH?
Pardon, sir?
Are there any side effects of using?
No. It will cause an irritation, sir, and you will get a mild erythema, and it may ulcerate. That's all. But it will heal without any scar.
Yes, please. The next slide. Dr. Sikha, next slide.
This is a 2-year-old child.
Yes.
You can see some grouped vesicles in the forearm as well as in the arm as well as in the back. Diagnosis: 2-year-old. No fever.
Vesicles on an erythematous base, if it is painful, looks like herpes.
So sometimes it may be painful.
Most of the people have answered.
Yeah, this is herpes zoster. So you have a multiple grouped vesicles on an erythematous base in a linear or dermatomal pattern with skipped areas of normal skin in between. So it is herpes. But we all know that herpes zoster occurs after an episode of chickenpox. This child never had chickenpox. Possibilities. How did this child develop herpes zoster?
People have replied HIV, immunodeficiency.
No. This is an immunocompetent child. So again you have to go into the retrospective history. Go to the mother. Ask the history in the mother whether she had chickenpox in the pregnancy time. In the second trimester of pregnancy, when mother gets chickenpox, nothing happens to the baby. The baby gets infected in utero. and within a year or two, they present with herpes zoster most of the time. Because normally in other children, when they develop varicella, the herpes zoster will occur after 20 years or 30 years. But here, when the mother develops it, when the child gets affected in utero, the second or third trimester, they can lead to herpes zoster in this child. Here again, the treatment is going to be simple. Topically, no acyclovir is going to work. So please do not use acyclovir topically for herpes simplex or herpes zoster. Just leave them alone. If there are erosions, we give antibacterial, and a calamine lotion can be given. And you can use acyclovir, 20 mg per kg body weight. 4 times a day is more than sufficient in small children. Totally 80 milligram per kg per day, you can use it for 7 days, then it will become all right.
Okay. Can we have the next?
So this is an 8-year-old female child presented with mild fever for 1 day, followed by a large patch on the upper back. And then it's an asymptomatic. Then after a week, it developed multiple lesions in the trunk. So we are almost in the viral infections. That is a clue. May be associated with fever, sometimes may not be associated with fever. More common during July to December.
P. rosacea is the answer that has come up in the chat box.
That's right. So it is Pityriasis rosea. It's not rosacea, it is rosea. Pityriasis means brawny scales, rosea means red or erythematous spots, right? So the white patch that you see on the upper back is a Herald patch, or we call it as mother's patch. It is very common between July to December, very common, but it can occur in other time also. Sometimes it be asymptomatic, like itching will be severe, or there may not be any itching at all. And you can develop daughter lesions after a week or two, and it will usually present in the coat sleeve area or coat sleeve distribution. That is how you wear a half coat. Particularly below the neck, up to the arms, up to the thighs, you can get the lesions. And there will be oval lesions, the transverse diameter parallel to the costal margin. So you'll get a Christmas tree pattern that may be present here. So how do you treat? Again, it's symptomatic management. If there is itching, give antihistamines. And here, you can, even though it's a viral infection, you can use topical steroids. Topical steroids in the form of mometasone or fluticasone can be applied. So for 2 to 4 weeks, they will disappear. The maximum duration of the disease is only 6 weeks. By 6 weeks, it will completely disappear. When you apply the steroids, the older lesion will disappear. But the new lesions, we don't have any control. They keep coming. You apply the medicine in that area also. So when there is itching, give antihistamines. When there is no itching, you need not give any antihistamine. Reassure them, it will disappear within 6 weeks.
Yes, Dr. Sika. Next slide, please.
This is a very small child. This child was around 6 months old. This child, they went to the beach. They put the child in the beach sand for some time. And after a few days, they saw these lesions on the back.
Yeah, people have answered, sir. Larva migrans.
Yes, this is cutaneous larva migrans. So it's very easy to diagnose. You can see the tract, the larva which has traveled, no, the tract that is very, very thin. Even if you don't do anything for this, larva is.
I think sir has lost the connection.
So you would like to continue ahead something? Because there are a lot of other slides which are.
Yeah, I think there are just few slides. Okay. I will continue. We'll go to the next slide. Please search.
You want to call him once, Dr. Rajesh?
Yeah, I will call him. I'll call him.
Ekwar, just try calling him.
I will just call him. Just give me a. He had a power failure problem there, but he said he'll connect back soon. Yeah, he's connected back. Hello, sir. Can you hear me? The screen shows that he is joined back.
Okay, you want to go on and he'll probably join. So we can cover as many slides.
Yeah. So this particular slide, it is very obvious. This is a case of atopic dermatitis. And this was a place where sir was planning to talk about the treatment of atopic dermatitis, where the mainstay of the treatment is always moisturizers. But then when it comes to the further treatment, we have to start topical corticosteroids. So there are different groups of corticosteroids with its potency. Next slide, please. Yeah, so you can see the potency rankings of the topical corticosteroids. Now, this is very important for us as a pediatrician in day-to-day practice because these are the class 1 are the super potent corticosteroid, clobetasol and halobutazole. They fall into this category, which should be reserved for very severe cases which are more there on thick skin. Definitely not to be applied on areas like face and axilla. Then comes
Yes,
class 2,
sir.
that is, yes,
I'm
sir.
online, sir. I'm
Yes.
Sir
online.
is there. Sir is
Yes,
there.
yes, sir.
I'm
Yes,
audible,
sir.
sir.
Yes, you are audible, sir. Please take on.
I'm sorry. There was a power, but we don't have a backup. Sir, actually, so this is the important topic for any pediatrician to know is the steroids. That is very, very important. We normally have an American classification where it is classified as 6 classes of steroids. Class 1 and 2, please keep off. Don't use these type of steroids. Particularly, look here, mometasone furoate, particularly. Ointment, you should not use ointment in pediatric age group. So clobetasol propionate and halobutazol, please keep off. But you can use clobetasol butyrate, that is different. So that is classified in UK classification, that can be used in pediatrics, but not this clobetasol propionate. Can you go to the next slide, madam? So fluticasone ointment, yes, you can go ahead. Mometasone furoate cream you can use, and fluticasone cream you can use. And the next group is desonide and hydrocortisone. These are the steroids you can use it. So please remember only these steroids you try to use it in the pediatric age group. You can go to the next slide, madam. So this desonide ointment and the least potent is going to be your hydrocortisone. So these are the steroids we can use, but you should know where to use and which ointments to use in which part of the body. That is very, very important. And what is the age group that has been allowed to use. Can you go to the next slide, madam? So the safe steroids in an infant, the FDA has recommended the steroids, topical steroids above 3 months of age group. Above 3 months of age group, like hydrocortisone, desonide, and fluticasone can be used above 3 months of age group. In the infantile period, you can use it. But fluticasone should not be used on the face. Whereas desonide and hydrocortisone can be used on the face. And you can use it twice daily for the period of 2 to 4 weeks, not more than 2 to 4 weeks. And please remember, you have to use mometasone above 2 years of age only, not below 2 years of age only. And you can use it once a day, that is more than sufficient. But when you are going to use it with your fusidic acid or salicylic acid, you can use mometasone twice daily. And mometasone should never be used on the face again. Again, it has to be used for 2 to 4 weeks, not more than that. How much to use? How much this steroids to be used? We normally say a fingertip unit. That is, you take any steroid cream. This comes with a standard nozzle, 0.5 centimeter nozzle. So you can use it from the adult index finger. You can drag it from the distal crease to the tip of the finger, which roughly makes 0.5 grams. You can apply to an area of twice the size of the palms with fingers closed. That is the area you can apply with this. But you can't explain this to the parents. So what we normally do is we calculate how much the steroid to be used, and we tell in their own language. A peanut size can be used, a pepper size can be used. Like that, you have to calculate and tell in a language which the mother will understand, so that you can apply properly the medicines. The too little medicines will not give any effect. Too much of medicine will lead to side effects. That is the problem we face. This fingertip unit, I have a picture. The next slide, you can see that picture. This is how you have to drag. On the index finger, you have to drag the medicine from the distal crease to the tip of the index finger, which makes roughly 0.5 grams, which is nothing but, twice the size of the palms you can apply. And adult palm size you can apply on the lesion. So how long to use? You have to use it only for 2 weeks and then review. Particularly in children who have atopic dermatitis, it is going to be a long-term issue, right? The dermatitis will not disappear like your Pityriasis alba. So here you have to always use a steroid, particularly on the face. You can use desonide and hydrocortisone. And if you are using desonide, you can use it for 4 weeks. Then after 4 weeks, you review the child and you can change over to hydrocortisone. After that, you can go for a non-steroidal preparation like tacrolimus or pimecrolimus. Or the other way of doing it is, if you use a steroid for particularly for 2 to 4 weeks, then you can go for intermittent usage. You can apply the same desonide on alternate days for 2 weeks, and then you can make it twice a week for another 2 weeks. Like that, you can use these steroids, and later you can switch over to a calcineurin inhibitors or a vitamin D analog, which doesn't have any side effects. The vitamin D analog somebody has asked is your calcipotriol. Calcipotriol can be used as a vitamin D analog. So these are the side effects you can come across if you use too much of steroids. So you have to be very careful. They can have an epidermal atrophy, and sometimes you can have, if you are going to use a potent steroid near the eye, it can lead to glaucoma and cataracts. Sometimes the steroid itself can cause an irritant contact dermatitis, and this class 1 steroid will have tachyphylaxis, not other steroids. And sometimes we get facial hypertrichosis also as a side effect when used topical steroids for a longer period of time. And the other side effects you can see is the next slide. So you can get any bacterial infections can get aggravated, and the scabies can lead to crusted scabies, and any fungal infections or viral infections can get exacerbated, and you can get perioral dermatitis also that can occur with the steroids. So you have to be very careful. So only those steroids which I told you can use it.
So I think we are coming to the end of the session, sir, because it's already 10:40 and
Okay,
we have crossed the stipulated time. I
Right.
know we can't cover the whole of dermatology in this one session. So I think we'll have to invite you again once again for the
No
lot of
issues, sir.
topics are still remaining.
Yes, sir.
But
I think
for
the
the
other
lack of
picture, what you
time,
saw should be a cradle cap. What you saw is a cradle cap. if
yes.
I'm right.
I thought of discussing all those things further, but
Okay, sir.
with the stipulated time, I think we'll have to stop here, sir.
Sir, and I once again
Yeah,
thank the IAP Mumbai, and hope this was useful to the pediatricians who have been practicing.
Sir, I would request Dr. Sikha to
Thank you so much,
Yeah.
Dr. Vijay Bhaskar, and thank you so much, Dr. Kasla. It was an enriching session, completely covering from skin infections to hypopigmented lesions in details. And I hope all our listeners have on their fingertip all how to use the steroids now. Yeah. Thank you so much, Kasla sir. And I'm sure we would like to have one more session because dermatology is so extensive and there's so many things that we can discuss further. A few slides we have left and those are very important ones. So I hope we can listen to sir once again.
Sir, if there are any questions in the chat box, sir, you can direct me to the WhatsApp so that I can answer when I have some free time, and then you can send it to those delegates.
Yes, sir. I would do that. And there is a request that if you can share that video of molluscum contagiosum removal, if you have on the WhatsApp group.
Yeah, definitely, sir. I will
you can share it to me. So I will send.
Sir, you have another 2 minutes time. 2 minutes
Yes,
time so that I can share it now.
Sure.
Just a minute, sir.
And Sikha or Rajesh, you can put it up in our Webflix group also, the video.
Sir, sir, I think I will share it into you in the WhatsApp, sir.
Okay, sir. Okay.
Because I'm finding it difficult to take it out.
Yes. So there are few questions which I couldn't take up because of the lack of time. So I would send the WhatsApp to you.
Sure.
And
sure, sir.
I will then reply back on this group to the delegates who have attended, sir. Thank you very much, sir. Thank you very much. It was really.
Thank you once again, sir.
Delegates for joining in such good numbers. Thank you all the delegates for joining in such a good number.
Thank you, Vijay Bhaskar, sir. That was really very comprehensive and very crisp, sir. Thank you very much. We are going to call you again soon.
Good night, everyone.
Thank you.
See you all on 28th. Please do come on 28th with your spouses.
Good day, sir. Good night.